At the outset, I would like to thank the scientific committee for having given me this opportunity to share my thoughts on the future of vitrectomy surgery. I thought I will begin with saying what is the change that we expect in the future, starting from the patient, the surgeon, the instrumentation, indications, etc. I guess in 10 minutes' time, whatever justice we can do, we will do. The changing patient profile is that the disease spectrum is likely to change. We already see there are more viral infections, there are more degenerative diseases that we manage than infective conditions of the eye. The patients are more demanding, which we all face every day, and fortunately they present earlier for treatment, unlike in the past when we used to see always PVR D3, a closed funnel configuration presenting 2 out of 3 times in the outpatient department. We see a lot more patients presenting to you early on when they develop a detachment of retina or any other problem. And they're also more knowledgeable. They come to you with a printout of the websites, giving the indications and contraindications of various drugs, etc. But that helps you really. Actually, it's not an obstacle for treatment, but it's very helpful to us because it's easier for us to explain to the patients the type of treatment, etc. There's also a changing surgeon's profile. There are more of now anterior cum posterior segment surgeons, not pure posterior segment and pure anterior segment surgeons. And I find that they are also computer and instrument savvy, which makes it easier for them to use the new instrumentation that is developing, coming into the market. I also find that they're more flexible and open to changes and adapt to the new developments much faster than old people like me. And perhaps more demanding as well. I don't want to specify what they're demanding. There's also a changing profile of eyes that undergo vitrectomy these days. You find that most retinal detachment that you come across would be, in the adult age at least, pseudophakic, courtesy the clear lens extractions being done under whatever excuse you want to give. There are also many patients who come with multifocal IOLs, and this poses a troublesome visualization during vitreoretinal surgery. Eyes with phakic intraocular lenses, eyes with scleral fixated intraocular lenses. Unfortunately, we still see patients with 2 intraocular lenses, one in the pupillary plane and one in the vitreous cavity, coming with retinal detachment. Sometimes the patient is aware of the second IOL, sometimes he is not. Eyes that have undergone LASIK, if we are not aware of that, sometimes we scrape off the epithelium and along with it the flap as well. Eyes with epiretinal prosthesis could come with retinal detachments in the near future once Dr. Rajat Agarwal is able to elaborate on his chip and enable it to be used on a routine clinical basis. Eyes with retinal inserts, like the fluoromisylone inserts, could also come with retinal detachments. There's also the new avatar of the vitrectomy cutter, which has changed from the 16-gauge cutters down now to 27-gauge cutters. So there's a reduction in the size, smaller the better. There's increased cut rate correspondingly, and there's also fluidics added to it, a la the phacoemulsification. The high cut rate has intuitively an advantage for the vitreoretinal surgeon. Because there's less traction on the retina, the amount of time the port is open is reduced between the 2 cuts because of the high cut rate, and hence it's a greater safety. You're able to go very close to the retina and trim the vitreous. But it does compromise on the suction efficiency for the same reason that the port is open for a brief period of time. So you need to increase the suction to compensate for this lack of suction efficiency. The so-called duty cycle and all would be beyond the scope of this discussion, that increases the suction efficiency. So the minimally invasive vitrectomy is a term being given wherein you don't put sutures, you make a tiny hole in the eye, be it 23 or 25 or 27 gauge, and try to finish the vitreoretinal surgery. And this is an advance, something like the phacoemulsification is for the cataract surgery. So the sutureless vitrectomy has become the norm now. In the past, we were just experimenting whether it is really good or not, but now it's been accepted as a good option. And the ratio of 20-gauge vitrectomies versus 23 or 25 gauge has reversed in the last 5 years. The majority of surgeries now I do are 23 or 25 gauge and not 20 gauge anymore. This is because of better instrumentation and gathering experience. But there are concerns. It's not as if it is totally foolproof. There is a concern of leakage from the wounds leading to hypotony. There's increased risk of endophthalmitis. This is again theoretical risk because not all reports and all series have shown an increased risk of endophthalmitis. There's lack of full armamentarium of the complex vitreoretinal surgery required for complex vitreoretinal surgery, especially the phacofragmentation unit, etc., etc. There are, of course, cost concerns in the developing world where most of these probes are not reusable, unlike the 20-gauge probes, and you have to destroy them. So, is scleral buckling on its way out? I hope not, because Charles Gibbons will turn in his grave. The rheumatogenic retinal detachment managed, if we say a case which could be managed potentially by both pars plana vitrectomy with the minimally invasive surgery versus scleral buckling, what is it that you as a surgeon are adding to the problems? One is in scleral buckling, there are extraocular muscle problems, there's more of postoperative pain and discomfort, there's induced myopia because of the elongation of the eyeball, there is risk of buccal intrusion and infection. This change in the refractive error is specifically a problem in pseudophakics with the multifocal eyeballs, etc. If you change the refractive error by placing a band around the eye, the whole advantage of the multifocal eyeball is gone. The risk of buccal intrusions and infections, the medial opacities are a greater interference for performance of scleral buckling, and there is also risk of anti-segment ischemia. So this is a list of complications that are induced directly because of surgery, while vitrectomy induces just one complication, that is higher incidence of cataract formation. So what is it that made vitrectomy a better option to manage these simple retinal detachments as well? It's because improved comfort level with pars plana surgery, ability to use minimally invasive surgery where there are no sutures, there's wide field visualization which allows you to see the retina in the periphery. It's elegant and definitely more comfortable for the patient. And more importantly, even during surgery, there's a very certain and definitive identification of all the lesions, and hence you don't miss any breaks at all, unlike scleral buckling where you can miss sometimes breaks. There is, of course, a reduced risk of intraoperative hypotony after a sort of drainage in a scleral buckling and associated choroidal detachment and hemorrhage in highly myopic eye. And this is indeed the choice of approach for eyes with thin sclera and a very high myopia. So, but still, there are currently indications for scleral buckling in simple detachment, though it would be restricted to RAD secondary to lattice with atrophic holes and no PVD, where you don't like to induce PVD in a young child. Simple detachments where gas cannot be used, somebody who wants to fly and is easily correctable by buckle, you would rather do a buckle so he can fly immediately. Where inducing a cataract is also a consideration like a young person, and very rarely a buckle is needed along with vitrectomy for simple detachment in inferior breaks, but even there I think the indications are reducing. Let us switch gears and go to the use of dyes and stains which can stain the various membranes in the eye and enable us to see them better and remove them better. There are various dyes which have been tried, of which I think the brilliant blue is perhaps the most commonly used presently. No longer is triamcinolone an important addendum, and no longer is ICG being used because of the toxicity considerations. So ILM peeling is currently done almost as a standard of care for macular hole surgery, aided by staining with brilliant blue, and there are better instrumentation, good 23 gauge instruments or 25 gauge forceps which can hold the ILM and peel it very nicely. The technique is fairly standard now, but the indications have expanded. Previously it was being used only for full thickness macular holes, but now we use not only for full thickness macular holes caused idiopathic or after injury, but even full thickness holes along with a rheumatogenic detachment due to a peripheral break as well. We try to do ILM peeling and not destroy the retina around the macular hole. But it can also be used for lamellar holes with pre-retinal traction, and it has been shown to be definitely effective. It can be used in routine PVR cases. If we do a ILM peeling of the macula, postoperative macular pucker risk is reduced. In epiretinal membrane, also now we remove the ILM along with the ERM so that islands of ILM are not left behind, because when you remove the ERM, the ILM gets removed in bits and pieces, and the resultant islands tend to proliferate and produce reoccurrence of epiretinal membrane formation, as well as the fact that metamorphopsia is reduced much better if we remove the ILM than if we leave the ILM behind. Tractional myopic foveal skies is an excellent indication for ILM removal. Pharmacological vitriolysis has been attempted using urea as well as microplasmin. There are lots of studies which have come supporting the use of microplasmin or plasmin, but still I think it has not lived up to the promise, in the sense those diseases where you really want the vitreous to separate along with the fibrosis, like a bad TRD due to diabetes, ROP, etc., or young patients with no PVD, it really does not matter at all, doesn't make a difference at all. Maybe in a diabetic it says the ability to induce PVD is enhanced, is easier. Beyond that, it has not made too much of difference. The use of densiron, there are again few reports of its utility, but I guess it should be used very selectively, like say a role in inferior breaks to avoid additional buckle. But there is a high incidence of early emulsification, and hence it has not caught up the imagination of the vitreoretinal surgeon. Endoscopic vitrectomy could potentially be used in selective cases where you would not like to do a corneal grafting along with vitreous surgery because the corneal haze is transient. It is likely to clear with time, and you don't want to unnecessarily add one more surgical procedure if you can avoid it. You fix the retina first, ignoring the corneal condition by going through endoscopic vitrectomy. You can also dissect better retroiridial and ciliary body covered membranes using endoscope rather than a high indentation during the usual surgical procedure. In surgery of retinal detachment in eyes with K-Pro, endoscopic vitrectomy will be extremely useful. So it's a good addendum to standard vitrectomy in difficult situations. It does not replace the regular bimanual surgery we do with ophthalmoscopic binocular visualization. A word about transvitreal delivery of drugs, devices and genes. These are made possible now. We deliver antibiotics every day in patients with endophthalmitis, but you can also deliver steroids using IVTA or more recently the slow-release devices like Ozurdex. Chemotherapeutic agents like methotrexate are also being delivered for reticulum cell sarcoma, the B-cell lymphoma of the eye. Subretinal injection of the RPE65 gene through AAV vector could potentially become a norm for the treatment of some of the patients with retinitis pigmentosa caused by mutations in RPE65 gene. And once that succeeds across the spectrum of the disease, we will be able to expand its scope to other gene mutations as well. Retinal processes, a word about the same. There are some developments, in fact a lot of developments have occurred in both the epiretinal processes as well as subretinal process. Epiretinal coming from United States and subretinal from Europe, in Germany especially. But there's still a lot of scope for improvement because the quality of image they see still is not very adequate, very useful for daily activities. But they are more mobile now with these procedures. But I guess you agree with me that there's more media hype to it than reality as of the present time. I'm sure in the next next few years, it may really become an important addendum to the management of a blind patient. So in conclusion, in 10 minutes, this is the justice I could do to this talk, that the future of vitreoretinal surgery is very rosy indeed. There are better instruments which enable us a more elegant management with least discomfort to the patient of majority of vitreoretinal diseases. More and more diseases will become treatable with gene therapy, etc. And some blind patients may become less handicapped with the use of retinal process. Thank you very much for your attention.